Hello and welcome to the Voice of the Patient podcast. We are the podcast working to change lives, that is, improve the quality of life through not only hearing, but truly listening to the voice of the patient.
Hello, everybody. Thank you for downloading this episode of the Voice of the Patient podcast. Today, our guest is Dr. Faye Reiff-Pasarew. Dr. Reiff-Pasarew is an assistant professor of hospital medicine, director of the Humanism in Medicine program, and unit medical director at the Icahn School of Medicine at Mount Sinai. She also produced the podcast series, The Art of Medicine. Her interests include the medical humanities, end-of-life care, and the doctor-patient relationship. You can find her on Twitter at The Art of Med. Dr. Reiff-Pasarew, thank you so much for joining me.
Well, thank you for inviting me.
Absolutely. So first, I want to start off mentioning that I found out about you because of an article that you recently published for the Washington Post. The article is titled, "I'm a Young Female Doctor. Calling Me Sweetie Won't Help Me Save Your Life." So I love the article. Could you just talk a little bit about what inspired you to write it?
Essentially, as a young woman in medicine, and I'm 34 years old, so not as young as some, but I was constantly getting comments by patients about my appearance, about my age. When I would go in and introduce myself as the attending who was supervising the care that they were receiving while they were in the hospital, I might get questions about, how old are you? When did you finish training? Just a lot of challenges about sort of my qualifications. And this was something that I discussed with other people I work with and found that it was a very common thing amongst younger women to get these questions. And, men do also get challenged on their age when they're sort of younger, newer out of training. But it seemed that there was a lot more challenging going on when it was women, and also that we got a lot of comments that were somewhat, if not sexual in nature, that were sexualizing. So, this was something that was very frustrating to me. I wasn't quite sure the best way to manage these situations. It didn't seem to be something that was really being discussed anywhere. So after one of these encounters where I was very frustrated with a patient who refused to acknowledge that I was a doctor, I became very upset when I came home, and I really needed a way to channel that energy in a constructive manner. Being angry about something isn't really very useful. So I wanted to think about how I could communicate this issue, get it out there for people to discuss so that hopefully we can come up with some better ways to approach it, both practically in the clinical moment, but also in a larger institutional or political way.
Great, thank you. And I can say from a different area of healthcare, being in physical therapy, these are still things that we see so much, and every healthcare provider will see it. So how do you typically respond in the moment when you hear things like that? In the article, you even mentioned that someone went so far as to say that they'd like to see a quote unquote real doctor. And I read your article and I got incredibly angry too. I was looking over to my wife and saying, this is crazy. But, it's stories that I've heard very often from classmates of mine, other peers and colleagues of mine. So how do you respond when you hear things like that?
Well, I think as we do in medicine all the time, you really have to assess the situation. So, whenever I'm in a medical clinical encounter, the first thing you need to know is sort of what is the goal of that moment, and how urgent is it? Obviously, if this were to come up in a scenario where there is something urgent medically going on, I may not have the ability to deal with it. If this is an emergency, if a patient is unstable, that patient care comes first. And so in some situations, I really just have to not acknowledge it at all and sort of just try to change the subject to the important business at hand. So, first of all, I think that, the clinical care takes top priority. if it's not an urgent situation and I do have the liberty of time and a moment to sort of process of what's going on, I try to understand whether the comment was given with good intentions or bad intentions. Sometimes I have people say things that are somewhat inappropriate or biased against women, but I feel that the person saying them doesn't really understand that they are. It doesn't mean them to be taken as such. And, I'm going to approach that situation differently than a patient who is hostile or who is in particular trying to challenge me because of my gender. Honestly, if I feel that the comment is not given with any sort of nefarious intention, I often don't have really the time or the ability to sort of discuss that with the patient. It's something that is bothersome to me, but in all honesty, I'm probably just going to ignore and proceed with what I'm doing and trying to create that connection with the patient. I think the situations where something really needs to be done is when I do have a patient who challenges me and says things that suggest that I wouldn't be able to take care of them as a doctor. And in those situations where someone's, say, actively challenging me on my age or my training, I don't think there's a lot of good guidance out there as to the best approach. And this is similar to people who are challenged for other reasons besides gender, whether it be based on their ethnicity or their country of origin, if they may have an accent. I don't think there's a lot of guidance. There are different approaches that I've taken, and I don't know what the correct one. I don't really think there's a correct one. I don't know what the best one, and eventually will be. But I sometimes might ask them, why are you asking me this question? Do you have concerns about my ability to take care of you? I think that it's a very awkward thing to ask someone that, but sometimes it's better to get those misgivings out in the open so that you can address them as opposed to having it sort of under the surface. Other ways that you can approach it are to try to explain what your background is and why you are qualified to take care of the person. You can tell the patient where you trained, how many years you've been working, and try to reassure them that you do have a lot of experience in this field. I think it depends on the situation. I think it depends on the patient. And it depends on whether you think that what the patient needs is reassurance or whether, they are someone who is actively trying to provoke you for other reasons.
That's a really good point. And there are so many different aspects of this that sometimes, like you said, someone might mean well. And it's a good example, if someone is from a certain culture and a different generation, then we can sort of see that there is, maybe they mean well, but there's still some prejudice there, that there's stereotypes there. But it's a very different story when someone appears to want to either get under your skin about something, or maybe that there's some actual hostility involved. And so that touches into something that we as healthcare providers don't have a whole lot of strict guidelines about exactly how to do it, because really the concept of therapeutic alliance really requires that the patient trusts you as a provider. So I appreciate how you mentioned actually bringing up a question of, do you have concerns about my ability to provide for you? So could you talk about a little bit of how those conversations go? Do you end up being surprised by how patients react? Maybe they react in a way that it establishes a better therapeutic alliance because of it, or maybe you've had any situations in which you've had to discontinue your care as a provider and transfer that to a different provider.
So I've never had to discontinue care. As a hospitalist, I'm often seeing patients for short periods of time, anywhere from a couple of days to a few weeks. And I've never had to stop seeing a patient because of this. I have, in some situations, had to have a patient representative from the hospital come in with me to address a patient who's being offensive. In one case, who was just repeatedly saying very offensive things to me and to the women that I was working with. And that had to be addressed. And we really, can't tolerate patients who are being really inappropriate in the hospital. Obviously, we don't always have a lot of control over it, but I think that, the hospital that I work at, and I think hopefully most hospitals, have some facility with a patient representative team or something else to sort of back you up and saying something that is offensive or racist. This is really not tolerated. There have been situations where I felt unsafe. I've, gone into rooms where patients have been threatening. But I have to say, in all of those situations, I was able to continue to take care of the patient. And often, even patients who are initially aggressive or threatening, if you take the time to hear them and to kind of work with them, you can often get to a much better place. That's not always the case. And, when there are other issues such as altered mental status or intoxication where a patient really isn't able to hear you, sometimes it's harder to deal with behavior like that. But no, I haven't had to stop seeing a patient. There have been patients who have refused to be seen by women. And in those cases, I never went to see that patient in the first place. And that's a very difficult situation because similar to when a patient may request to only be seen by a white provider or something similar, how we deal with those situations is very tricky. On one hand, we don't want to do anything that supports that type of behavior, but at the same time, we don't want to send providers in to see a patient who may be actively hostile or racist or sexist towards them. And we may not agree with their behavior. We still have to take the best care possible of that patient. So it's very, very tricky. And I think that institutions need to think more and more about how we manage these situations.
Absolutely. And in your article, you mentioned how providers could take the approach of merely hoping the arc of history bends toward gender equity. But are there things that, as healthcare providers and members of bigger institutions and part of the wider healthcare industry, what sort of things can we do to try to bend the arc ourselves?
Well, I think one thing that we can do, and this is happening a lot more recently than I'd seen before, is doctors and other medical providers, everyone in the healthcare system, we need to be more politically active. And that can mean a lot of things. I think at a very basic level, our healthcare system is really in a moment of a flux right now, and nobody's really sure what's going to happen. But I think that those who work in the healthcare industry, we have the most information about what the problems are, what the issues are, and we need to be part of this discussion. And I think we're only going to be part of this discussion if we actively ask to be. And that means taking more of a role in our professional organizations. It means running for office. It means advocating for things that we care about. This can encompass a lot of different political issues. But I think that for a long time, people in the medical field have not played much of a role in political discussions that had to do with health and medicine in this country. And I think that needs to change.
I completely agree. And it's an important thing to mention that, and this is bigger than any one healthcare profession, but really about the entire industry, because we, as different providers operating in different disciplines, we still want what's best for that patient, for that person. And this really is a matter of wanting what's best for essentially society, for everyone's health. And it can be hard to do that if the legislators don't really have that same end goal in mind. So I love that you mentioned that. And I do agree that I think that's part of the answer is the need to be more active with policy and to make sure that our voices are heard because of that end goal of having patients in mind.
Yeah, and I think that even at a more local level, being active in what your institution is doing makes a big difference. Healthcare institutions, whether they're hospitals, clinics, insurance companies, whatever you are involved with, they are huge players in this system. And if there are things that your institution is doing that you agree with or don't agree with, get involved with that. If there are projects that you believe in, be a part of that. That is sort of the first step is seeing what is being done at the local level in your own institutions, and how can you be a part of that? How can you ensure that your institution is living up to the ideals that you hope it would? I've been very lucky at Mount Sinai to be someplace that I think is very forward thinking and progressive, and has really been very supportive of issues that affect our patients and our staff. That may not be the case everywhere, but whether or not it's the case, I think that we all have a responsibility to get involved with what our institutions are doing.
So true. And that touches on something that you mentioned in your article about inviting patients to grand rounds. Could you talk a little bit about that and how that's changed or affected your practice?
Sure. So our division grand rounds are usually lectures. Sometimes they may be slightly different than that. And usually they're a lecture by another physician on a medical topic, on research, on new programs in the hospital. And it's given to all the members of our division, which include nurse practitioners, physician assistants, and doctors. And I really feel that in many cases, it's very hard to really get a sense of what our patients experience when we're not taking care of them. As hospitalists, we see patients at their worst. We're not seeing them in the clinic. We're seeing them when something very bad has happened and they have ended up in the hospital. So they're very sick. That's not really a good representation of what they are normally or what their potential is. And I think that even though we all know this, it's very hard to really believe that. So in particular with groups that I think there's a lot of bias towards, I wanted to invite people to our grand rounds to talk about what their experience was, not just as patients, but as people, what their experience was living with whatever illness it was that brought them in on the days that they're not sick, so that we could have a better sense of who we were taking care of. I've done this twice so far. I'm going to do it more, hopefully. And the two groups that I had come in, the first one was, the theme of it was really about disability. We take care of a lot of patients who have disabilities, and when they're sick in the hospital, they are not able to do what they normally can. And I think often we don't realize their true capabilities when they aren't sick. So I invited a patient who has very severe cerebral palsy and uses a wheelchair and has some challenges with communication, to talk about what his life is like when he is well, how he works, how he enjoys himself, how he gets around, the way that society treats him. The second one that we did was about sickle cell disease. We have a large population of patients with sickle cell disease at our hospital, and there's a large population in New York City. And we had 3 people who live with sickle cell come in and talk about their experiences interacting with the healthcare system. There is a lot of bias and there's a lot of assumptions about these patients, these people, that aren't true. And I wanted our providers to hear from them what it was like to interact with the medical system from their perspective, and also what it was like to live in the world with this illness. And I think it was really a very positive experience for the people who came. The guests really enjoyed it, and I got a lot of positive feedback from the people who came to the talk as well. So hopefully I'd like to bring in more people. Other groups that I think would be very interesting to have represented might be people who have struggled with addiction, perhaps patients who have dealt with homelessness. There's a number of different groups that we treat for whom I think a lot of assumptions are made that influence their care, and I would love to hear their stories.
I think that's awesome. And I love that you'd mentioned that when you see a patient in the hospital, you're seeing this person at a snapshot of their life that is incredibly stressful, potentially the worst time of their life. And so to be able to bring someone in and get a bigger view of how their life is, I think just provides a better, more well-rounded view as healthcare providers to understand where this person is coming from and to understand how your care should take that into consideration. So this sounds like this touches on a term that I read in your article that I don't hear very often, that of narrative medicine. Could you elaborate on what narrative medicine is for our listeners who might not be familiar?
Sure. Narrative medicine is a discipline that exists within a field that I would call the medical humanities, or sometimes maybe called the health humanities. The medical humanities, more broadly, is an approach to understanding health and illness and the medical system through the lens of various disciplines, in particular the humanities and the arts. What this means is that though the biological model is very helpful in understanding disease and vital to the work that we do, if we truly want to understand the experience of our patients and we want to be the best care providers that we can be, there's a lot that we need to know about the history of those illnesses, about the psychology of dealing with those illnesses. We may learn through expression of providers or of patients, and that may come through the arts. It may come through writing. It may come through performance of various kinds. And so within this larger field, the discipline of narrative medicine is a specific approach. It is a scholarly field that was developed by Rita Sharon at Columbia about 20 years ago that seeks to really understand the experience of patients and caregivers through the stories that they tell. And it takes a particular approach that is very rooted in narrative theory and literary theory to access the experience of people moving through the healthcare system in various ways. And, there's a lot more that I could say about the field, but it's one example within the larger field of the medical humanities of sort of a new understanding that just treating an illness may not be enough to really care for someone. And I think there's increasing awareness at least in medical schools, if not elsewhere, that teaching these other skills of understanding the experience of illness are really vital to creating, excellent practitioners.
I think that's excellent. And speaking of medical schools, that reminds me of how you mentioned in your article that as a professor that you have used poetry to teach medical students about diagnosing cancer. Could you talk a little bit about that? What is that like?
So, I've taught classes in the medical school and also for social workers and various other people in the healthcare system that draws a lot on the medical humanities and in particular on the work of Rita Sharon with narrative medicine. And we use poetry and visual art, film, movies, lots of different media, even ad campaigns, to try to understand the experience of illness. So in some cases, that may be reading poetry that is from the perspective of someone being diagnosed with cancer. It could be looking at ad campaigns raising awareness for a disease. It could involve free writing by students about their own experiences. And what all of this is meant to do is to try to open up our minds a little bit and get us to understand the perspective of others. I think that one of the main complaints that patients have about doctors is that they don't listen, that they don't appreciate their perspective. So what I'm trying to do is through the use of poetry, fiction, visual art, anything, trying to get people to really be in the practice of thinking about other people's perspectives and how they express themselves, and to let that guide how we take care of that patient. whether that means the tone that we use, the way that we explain things, just understanding who this person is and how we can best help them. There's such a large psychological component to all illness, in the sense that, people have a lot of fears. They have grief when they're diagnosed. They have, in some cases, depression. They have so many what we might call comorbidities that are psychological. And if we're not taking the time to listen to them and hear what those are, we're not going to do a great job of treating them. If someone is very scared, they may not show up to their appointment. They may not take their medication. They may not take care of themselves properly. So, these are really important things to understand when you're trying to devise a care plan for someone.
Definitely. And it really actually reminds me of my experience in physical therapy school. I recently graduated, and it's similar to a one day in class that we had. We actually went to an art museum. And my professor, Bill McGee, he really wanted to lead us through the museum for a couple different reasons, one of which being that when you see a piece of art, you automatically have some reactions to it. And sometimes those reactions are not correct, they're not what the artist intended, or you might be totally missing something that the person next to you sees quite clearly, and vice versa. And very often you see something and you make a snap judgment that may not be founded on anything that's accurate, or it's something that you're missing. And I thought that was amazing, an opportunity to really see how it's related to our reasoning as healthcare providers, but for many other reasons, just like you said. And I was really pleasantly surprised to see that really my classmates loved it as much as I did. So could you talk how have your students responded to some of those exercises?
Well, I think that, it's very interesting. So certain workshops or classes that I've done have been open and students can choose to come to them. And I think that when you do that, you get a select group of students who are more interested in expanding their skill set in this way. And that's different than if you're teaching a group where everyone is required to be there. And I've also been involved in classes like that. I think that it's obviously a little bit more challenging when you have people who may not be as interested in a humanities approach. However, I think that sometimes, particularly in medical school, but probably elsewhere in the health professions, you have a lot of students who have been very high achieving and very focused on sort of very specific benchmarks of their success, whether it be grades or test scores. And sometimes it can be very unnerving or uncomfortable to enter a classroom where there isn't a clear test, when there isn't a clear way to rate their success, where we're asking them to be a little bit vulnerable, to be a little bit open to new ideas that may be uncomfortable, that may be challenging to their understanding of things. And that makes people uncomfortable sometimes, and that's okay. When I was in college, Ruth Simmons was the head of my college, Brown University, when I went there, and she's an amazing woman. And she said when we started, that college is supposed to be uncomfortable. Learning is supposed to be uncomfortable. If it's not making you uncomfortable, then you're not really being pushed to learn anything new. Your preconceived notions are not being challenged. You're not being put into a place where you are forced to feel a little bit, off your game. That's actually a good thing. If everything feels just easy and comfortable, you're missing out. You're not pushing yourself. You're playing it too safe. So it's okay if these types of approaches don't come naturally to everyone or make people uncomfortable. I think that doesn't mean that they don't learn from them. And I'm constantly trying to put myself into learning environments that may force me to be a little bit uncomfortable and to see things in a different way that I'm used to seeing them.
And I imagine that was part of what led you to start the Art of Medicine podcast. It's about really exploring different areas of humanity that's outside of medicine, but really in a way you could argue are really fundamentally important to medicine. Could you talk a little bit about what led you to start the podcast?
I started the podcast a few years ago because I really felt that there was something lacking in the discussions around medicine. And what I mean is that we were missing the sort of other vital perspectives that come from other disciplines. So for instance, I thought that it seemed very difficult to understand what a person with sickle cell disease might feel walking into a hospital without looking at the history of sickle cell disease and thinking about the social and political events that have occurred over the past century relating to this illness. So for instance, just the fact that until the second half of the 20th century, this illness was really not even acknowledged as a true illness. And then even after the genetic etiology was clarified, there was a huge amount of discrimination against people with this disease. And so for an older patient that we treat, they may have lived through this. And for even a younger patient, they may have heard about this, or they may have family members who lived through this. And if we're not thinking about the history of this, how can we possibly truly take care of this person and understand what their perspective is when they're coming and seeking medical care? So I did an episode specifically on that with sort of a historical and patient-centered approach. Other examples might be an interview that I did with a dancer who was diagnosed with Parkinson's disease, and how her experience of her own body changed through having this movement disorder. We don't think enough about the implications for someone of these illnesses, not just do they have pain? Will they live or die? What is the treatment cost? Those are the things that are talked about. But what does this mean to somebody's identity? What does it do to their profession, their interests? How does it affect this person's life? So I wanted to hear about that. I interviewed a person who was born intersex, a person who had ambiguous genitalia, to talk about their experiences. This is something that's actually much more common than people discuss, and the medical community has not done a great job of taking care of these patients. So I wanted to think a little more psychologically and sociologically about what the implications are for someone who is raised with all of these sort of very difficult medical experiences around their ambiguous gender. For me, it was a way to reach out to gather knowledge from other disciplines to better understand the illnesses that I was treating and to better understand the people with those illnesses.
That's wonderful. And it's really also in a different way, part of the inspiration for this podcast here, The Voice of the Patient, which is really to find ways to develop a better connection with people, to really listen to the voice of the patient as best we can. And like you've said earlier in the episode, that a big criticism that people have of just any healthcare provider might be that they don't feel like that the provider cares or is listening about the person. And so I just love what you've mentioned here in this conversation, also in your article, about finding ways that we in healthcare can really understand people better, and also to try to develop a better, stronger relationship with people as healthcare providers. So I thank you for that. And is there any final advice or parting comments for other healthcare providers out there listening?
In terms of advice, if you are interested in something that may seem slightly outside of the scope of what you're doing, you should pursue it. I think that medicine can be very traditional and a little narrow-minded sometimes about sort of what is the proper career path, what is the proper way to succeed, what are the activities you're expected to do, whether it be research or teaching or whatever it may be. But there is a lot of need for healthcare providers to be a little more broad-minded about what they do, whether that means being politically active, whether that means writing about their experiences, teaching about their experiences, getting involved in the medical humanities, or anything else. We have a lot to share. And I think that don't be afraid to pursue ideas that you have that you don't see anyone else doing, but that you think would be beneficial for you or for the healthcare system or your patients.
Great. Thank you so much. And how can our listeners contact you with any questions or comments?
Well, you can get in touch with me through Twitter at The Art of Med, or you could also email me at Faye, which is FAYE, at theartofmedicinepodcast.com. Either of those ways would be fine.
Great. Thank you so much. And thank you again for your wisdom that you shared here in the conversation and in your article in the Washington Post, which I will link to in the show notes, as well as the Art of Medicine podcast and to your Twitter account. So Dr. Reiff-Pasarew, again, thank you so much for our conversation.
Thank you so much.
And to our listeners, thank you for listening to this episode. If you appreciate the voice of the patient, then leave us a review on iTunes. If you have a story to tell as a patient or a provider or both, then please find us on Twitter at Zach R. Stearns or find Dave Reed at DReedPT. Thank you again, and keep listening to the voice of the patient.
If you enjoyed this episode, go to thevoiceofthepatient.org, where you can find other helpful podcasts and blog posts that will show you how to improve healthcare through not only hearing, but truly listening to the voice of the patient. Thanks for listening. This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.